Okay, so I think we are live on YouTube now. I'll just reclaim the host. Okay. Hmm.
Thanapan wants unmuting himself, sir. Jayesh?
Yes, sir. I'll do that. I'll do that.
Now the participants have reached 100, 101.
Yeah.
One not one, sir.
Right time to start.
So shall we start, sir?
Shall we start?
Yes,
Yes, sir,
Thanapan,
yes,
sir,
sir.
you can unmute, sir.
Okay, sir. Good evening, sir. Good evening, sir.
Good evening to all.
Amir, sir. Good evening, sir.
Shall we start?
Suresh, sir. Good evening.
Yeah, good evening to all
Sir,
of
good
you.
evening, good evening, sir.
Good evening,
Thanapan, sir, good evening. Sir, shall we start, sir?
We can start.
Yes, sir. Sir, on behalf of TNOA, we welcome our faculty members today. Professor Samuel Jnanam, my teacher and a very great clinician. I've learned a lot of clinical skills and examination skills. I will be so many times. I'm also surprised. Very complicated cases, sir will be able to give exact diagnosis clinically without seeing the X-ray, and after seeing the X-ray, the diagnosis will be very perfect, sir. So I don't know how you develop that skill, sir, and till I'm practicing, I'm not able to go to that level of your clinical examination skills, sir. And also we have another expert pediatric orthopedic surgeon, Dr. Suresh Babu in ICH. He's specialized in pediatric orthopedics, so he's got immense knowledge and great experience with respect to pediatric orthopedics and all deformity and all kind of corrections he does. I also welcome Professor Balachandra sir, who has joined in. My Chodi in Government Rayapeta Hospital, another one of my teachers, Dr. Mohan sir. Mohan sir also is my teacher. I know we are in Rayapeta and KMC, so many teachers are there. And today they've all joined, feel very happy. I also welcome our secretary of TNOA, Professor P.T. Saravanan, who's been the backbone of organizing all these TNOA teaching programs in spite of his very busy schedule. And I also welcome my coordinators, Professor Thanapan from Madurai Medical College and Professor Suresh from Tirunelveli Medical College, who are the brain behind the entire teaching program. And I also thank our advisors, Dr. Vetrivel Shetty, Professor Vetrivel Shetty and Professor Singaradivel sir, for having guided us to this. So today we'll handing over to Professor Samuel sir and Dr. Suresh Babu. So they will brief the PGs about what we are planning today. Sir, over to you, sir. Professor Samuel sir and Dr. Suresh Babu.
Good evening, everybody. I'm happy to be here. And first of all, I'd like to thank the TNOA President, Secretary, and all the Executive Committee members for giving me this opportunity to be here this evening. I'm glad to see Balachandra sir, Mohan, and all my old colleagues here now, Suresh and Thiru, everybody. And thank you, Saravanan sir. We'll, our format is I am going to present one small or short case with a photograph and a gist. The PGs can go through it and take some time and then start presenting. Since we don't have a patient to be examined, we'll take it in a loosened way. Shall I start?
Yes, sir.
Sir, yes, sir, you can go ahead, sir.
Yeah.
Yeah, with uncle. Play board.
Chodan and Salman, sir. And the PGs வந்து Salman and Chodan, sir. Chodan and Salman, நீங்க unmute பண்ணிட்டு உங்க வீடியோல ஆன் பண்ணிக்கோங்கப்பா.
Screen visible on again. Screen visible on again.
Is the screen visible?
Yes, sir.
Yes, sir. Yes, sir.
Yeah. So, Chodan and Salman, I'm just going to give you 2 or 3 slides. You can just go through it. If you want, you can take a screenshot of it and go through it. We'll give you some time and later we can present it. Okay? So, this is a short case. So, a 35-year-old male patient presented to OPD. He's a plumber by occupation. A complaint of increasing swelling in the left elbow for the past 6 months with minimal restriction of movement and sensory disturbance in the left upper limb. And being a plumber, he was finding it difficult to use his left upper limb for daily activities. On examination, there's a grossly swollen left elbow, not much of tenderness, multiple skin lesions were there, and some abnormal mobility of the elbow was also This is the clinical picture. This is another view of the picture. You want me to show the picture?
So can you please show me the screen?
Shall we give some time for the PGs so that shall we go for the next presentation? Later we can call them for presentation.
Yes, sir. We can go
Yes,
for
sir.
next presentation and we will call this after the next presentation.
Please stop sharing.
Can I start presenting my cases?
Yes, sir. So this second case is for allot the PGs for this, sir. Then Thiru sir.
In case on the allotted, sir, Azhar and one more, Navneet. Azhar and Navneet.
Now,
Azhar-
okay,
Azhar is here?
you both.
Navneet has responded. Azhar has not yet responded.
Okay, no,
I
you
want-
start. We'll go give it to Navneet and ask him to unmute and.
Yeah, Navneet is unmuted.
sir,
sir.
I'm-
Already is unmuted. Yeah.
Okay.
Suresh, you can proceed.
Yeah.
நீங்க screen share பண்ணிடுங்க.
Suresh, sir, you can share your screen, sir.
Yes, yes, yes. Sir, how to go to my presentation?
Sir,
Sharing.
can you
Kira,
click
share
it,
screen.
share screen, sir.
Okay.
Yeah, sir.
Okay.
The second
Yeah, I
postgraduate
got
name is Salman, sir. Salman, not Azhar. Salman.
இல்ல சார் சால்மன் கொடுத்துட்டோம் சார் ஆல்ரெடி சால்மன் சோட இதுல இன்க்ளூட் பண்ணிட்டோம்.
Appa Vignesh, sir. Vignesh from
ஓ
MMC.
அதான் சார் நீங்க அசர் நான் அசர் கேட்டுட்டே
Vignesh
இருந்தேன்.
from MMC, sir. I think he's here. You have to
Sir,
unmute
என்னோட
him.
screen தெரியுதா சார்?
There is, sir.
So there are three Vignesh, sir. Vignesh M, Vignesh iPhone, and Vignesh.
So who is going
Shivam.
to take this case?
Sir, I will tell you the number, sir.
Okay, sir, I have unmuted him. Yes.
Okay. 94444039998.
He message in the inbox. You check it.
Okay.
Yeah. Yeah, Vignesh M.
Yes, sir.
Can I proceed?
Yes, sir.
I am going to show two case scenarios. The first case, a 5-year-old girl child. She had a history of injury to the right elbow due to fall on the outstretched hand while playing at the school 1 year back. Following which she developed some pain, swelling, and not able to move. Then she was treated by native bone setters. Now the patient's parents come with complaints of deformity of the right elbow. As per the parents' history, the deformity is not increasing, and there is no functional disability, there is no pain. Clinical examination, there is obvious deformity seen. There is no warmth, no tenderness, no sinuses, no scars are seen around the elbow. On palpation, the bony triangle is maintained. There is a minimal thickening on both the supracondylar ridges. Movement is minus 20 degree, that is 20 degree of hyperextension up to 120 degree of flexion. There is no distal neurovascular deficits, and proximal joint, shoulder joint, wrist joints are clinically normal. So this is a clinical picture of the child. So you can see only the intraoperative pictures are available. The clinical picture. So I want to ask 5 questions to the PGs. What is the name of the deformity? And what are all the components of this deformity? Then how will you measure each components of the deformity? So I request all the PGs, you can take a screenshot or you can take a video picture from the mobile so that you can remember all the questions, because I combined the questions in 2-3 questions in a single question. The name of the deformity, What are the components of the disability? How to measure? That is question number 1. Second question, what is your clinical diagnosis? What are the differential diagnosis you want to offer for this clinical condition? Third, from this history and the clinical picture and from the clinical examination, and what investigations you will order? Then what are the radiological findings you will look into this section or in the whatever investigations you are ordering? Then what is your plan of management? When will you advise treatment for this particular child? And if you are deciding to do surgery, then where is the fora for this particular deformity? And what type of surgery you will do for this particular condition? So the PG is clear about the question. The PG
Yes,
who is
sir.
going to take this case.
Yes, sir.
Very clear?
Yes, sir.
Okay. So can I go to the second case?
We'll finish these 2 cases first, and then we will start the third case, sir.
Yeah. Yes, I have to. We'll close
Or you
this.
can give the second case also.
No,
Yes,
no, I
sir.
can give the second next.
Second case kudutharalam sir, so they'll have some time to prepare.
Yes.
Okay.
Who is going to take the second case?
The same people, sir.
The
Okay.
same team only, the same team only.
Three
Suresh.
PGs are sitting together, is it?
இல்ல ரெண்டு பேர் இருக்காங்க, தனித்தனியா இருக்காங்க.
Okay, சரிங்க.
So one can
This
take
is-
the first and one can take, Navneet can take first and
Okay, sir.
Vignesh can take the second.
Yes.
Okay, sir.
This is a 9-year-old male child. He had an injury to the left elbow due to fall 8 months back while playing. Then he sustained he developed some pain and swelling in the forearm. So he was treated with above elbow POP for a period of 3 to 4 weeks. After that, he was normal. Then gradually, so now he came with complaints of difficulty in bending the elbow for the past 6 months. They noted only past 6 months. And they noted the swelling in the antecubital fossa of the elbow. And that there is a complaining of deformity. And he says he's pain while leaning on the hand. For example, while getting up from the bed with weight bearing on the wrist, he says he is getting some pain in the elbow. On clinical examination, there is a swelling in the antecubital fossa. It is bony hard in consistency. It is round and smooth. And swelling moves with the rotation of the forearm. It is not tender. The bony triangle is maintained. And clinically, there is a cubitus valgus deformity, and also there is some amount of lateral instability. That is, valgus stress is positive. Valgus stress is positive. The movement is flexion is 0 to 100 degree, supination is 80 degree, pronation is 70 degree. No distal neurovascular deficit. So this is the clinical picture. You can see the movement flexion is restricted. So you can see the cubitus valgus deformity. Can you see the swelling here?
Yes, sir. I can see.
You can see the small swelling is felt in the antecubital fossa. The swelling moves with the rotation of the forearm. So the questions to you is: so what is your clinical diagnosis? What are the investigations you need? And what are the radiological signs you will look into? So what is the natural history of this particular condition? How will you manage this case and how to prevent this condition? So what is your clinical diagnosis? So what are the investigations you will do? So what radiological signs you will see? What is the natural history of this condition? So what is your management in this particular case? How will you avoid or how will you prevent this particular clinical condition? The questions are clear?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Okay. So now I stop with this. So I think now we'll go to the
First case.
first case.
Yeah.
சுரேஷ் நீங்க உங்க பவர் பாயிண்ட் ஸ்டாப் ஷேர் பண்ணிடுங்க, ஏன்னா உங்க இதுல இது இருக்கு. சோ ஐ திங்க் யூ ஹேவ் டு ஸ்டாப் ஷேர். எல்லாம் பவர் பாயிண்ட் க்ளோஸ் பண்ணிடுங்க. பவர் பாயிண்ட் க்ளோஸ் பண்ணிடுங்க. யா
ஓகே.
Sir, Thiru sir.
Yeah, yes Ramesh.
Sir, actually some of postgraduates, they are giving answer in YouTube also.
Okay.
So you can take it from there also, sir.
இல்ல no answers.
Discussion
only discussion அப்ப ஆன்சர்
people-
பண்ணிக்கலாம்.
Yeah, some of people, they reply in the YouTube also. That's why.
No issues.
Yeah, let them let them interact. அது ஒன்னும் இஷ்யூ இல்ல. But sir questions கேட்க ஆரம்பிச்சதுல இருந்து then they can go ahead.
First, the postgraduates which are present in the online meeting, they have to give the preference. After that, only the rest of the audience.
Yes.
Yes.
So Salman and
Choran.
are ready?
Yes, sir.
First case கொஞ்சம் tough case sir. ரொம்ப tough case கொடுத்துட்டீங்க sir first case.
tough case. Thiru, why I am not able to see the screen out?
இல்ல சுரேஷ்
நீங்க stop sharing போடுங்க.
Stop share.
ஷேர் ஸ்கிரீன் இருக்குல்ல, அங்க போய் ஸ்டாப் ஷேரிங் கொடுங்க.
ஓகே.
எஸ் சார், அந்த ஃபர்ஸ்ட் கேஸ் திரும்பி போடலாமா சார் நம்ம?
போடலாம்.
எஸ் சார்.
interesting case, sir.
Yeah, actually I didn't have the full details of it, but it was very interesting and out of the way case. I thought I will share it with you.
You can once again highlights the features, sir, then we can go for discussion.
உங்களுக்கு ஏதாவது டவுட்ஸ் இருந்தா கேட்டுக்கோங்கப்பா. Salman and Choran, you have any doubts you can ask sir about the palpatory findings. அதெல்லாம் வந்து கொஞ்சம் நீங்க வேணா you can ask.
The examination finding you want to know, you please ask.
So it's a grossly swollen elbow with a boggy type of swelling all around the joint. Some abnormal mobility is there, and sensory disturbance is there in the limb. And anything else you want to know?
Is there any procedures done?
Some restriction is there, 10 to 15 degrees on either side, but abnormal mobility is there.
Sir, you told some skin patches.
Is there any procedures done in the scars?
No history of any procedures.
What about the skin lesion, sir? Any skin PGs want to know anything about the skin lesion?
It seems we can easily say this.
The swelling is gradually.
Don't worry about the skin lesion. It may not be, I'll give you a clue, it may not be connected to the diagnosis also. We can try to find a.
Sir has given.
You concentrate on the elbow.
Okay, fine. Sir.
Actually, the swelling
concentrate on the elbow.
Progressively increasing for about 6 months. The restriction of movement and sensory loss is also.
Pardon? I'm not able to hear you clearly.
Choran, ரெண்டு இது ஆன் பண்ணாத Choran. ஒரு இது ஆஃப் பண்ணிடு.
ஆடியோ கிளியரா இல்ல.
இல்ல நீ ரெண்டு கனெக்ஷன் வச்சிருக்கேன்னு நினைக்கிறேன். நீ
You
க்ளோஸ் பண்ணு, ஒரு கனெக்ஷன் க்ளோஸ் பண்ணு. ஓகே ரைட். Yeah, go ahead.
Gradual increasing of swelling size of for 6 months and restriction of movement and the sensory loss is also there. I just want to give a differential diagnosis of
sure.
Of neuropathic joint, or else any synovial disorder producing synovial hyperplasia like that, producing there is amount of diffusion.
Okay. Any other different diagnosis? So first, for your first this is neuropathic joint.
Neuropathic joint.
Right.
Synovial disorder.
Second one is
synovial hyperplasia.
Synovial chondromatosis சொல்றீங்க.
Synovial chondromatosis or synovial sarcoma.
Or pigmented villonodular synovitis or synovial sarcoma.
Synovial sarcoma. Okay.
What can ask other postgraduates also, sir. He can also have his own. Solomon can give his view also.
Sir, the patient have any constitutional symptoms, sir? Loss of weight.
No constitutional symptoms. No, nothing marked.
Choran, you're not thinking of any infection? Any type of infection?
Yes,
or
but
differential diagnosis?
Yes, but there is no symptoms, clinical features suggestion of infection because he is having progressively increasing for 6 months. But tuberculosis is also one of the disease, but he is not having any loss of weight, loss of update evening rise of is not in this case. But differential diagnosis, tuberculosis also.
Yeah, good. I
Yeah, you
think
can
you're on the right track.
ground-based tuberculosis, yes.
I think you're in right track. All the diagnosis, differential diagnosis you're given is okay. First you said Charcot's joint, then you said some synovial chondromatosis, and then maybe a septic or a tuberculous arthritis, right? What made you to put Charcot's joint first?
Sir, Charcot's joint by there is nerve lesion is also there, sir.
Pardon?
Nerve lesion. There is lot of
Good. Yes, I told you there's some sensory disturbance. Right?
sensory disturbance.
I didn't elaborate on that.
Swelling is also looks like boggy swelling.
Yes.
It also slowly progresses to 6 months duration.
Okay.
Important point is there is no pain. You just concentrate on the.
There is no pain. Yes, sir.
Painless is not there.
Painless swelling. Yes, sir. Painless swelling.
Muscle wasting is also very minimal, sir. Manu, muscle wasting avlo pronounced illa. Muscle wasting irukka, sir? Is there any
muscle wasting? Not much.
Yes, sir. In infective pathology, there will be severe muscle wasting.
Not much. And any other point? What is the etiology you think? What is the reason for the Charcot's joint?
So the only thing in history is plumber by occupation, sir.
Pardon?
Plumber by occupation.
Plumber by occupation.
Yes.
There is no other thing in the history, sir, other than age reason. Maybe due to lead poisoning.
Lead poisoning?
Chronic lead poisoning is meaning.
Chronic lead poisoning.
Lead poisoning, you get motor weakness, no?
Yes, sir, but
what do you get? Can it be Hansen's?
Yeah, you would think of cancer.
Hansen's, there is complete sensory loss of left upper limb was there. There is no peripheral nerve lesion.
You concentrate on his hand. You had a look on his hand. You see his thumb? Anything?
Thumb. There is partially amputated, sir.
Yes.
It looks like.
But the skin lesion doesn't look like Hansen, right?
It looks like some. Yes, sir.
Any other diagnosis in mind?
So, what is the commonest cause of neuropathic joint in elbow? In commonest cause?
Yes.
Salman can also answer.
Salman?
Sir,
साफ पता चल रहा है लड़की अंदर जवाब भी नहीं रही इसे क्या पता चलता है आपको पता चलता है कि कुछ भी नहीं पता है
Okay, this is shall I proceed?
Yes, sir.
I'll give the X-ray, then you can tell your diagnosis.
Solomon can read the X-ray.
Read the X-ray.
Solomon.
Sir.
You please read the X-ray.
Sir, it's a mature adult X-ray of AP and lateral view showing a gross destruction of the articular surfaces.
Side of the left elbow.
Of left elbow, with a gross destruction of articular surfaces.
Yes.
And yes.
Multiple loose bodies.
Multiple loose bodies with a.
You can see the soft tissue proliferation also.
Yes, sir. Sclerosed ends, sir.
Yeah, gross destruction of the condyles as well as the proximal forearm with multiple loose bodies and new bone formation. You can see some new bone formation here. So what's your diagnosis after you can see the electron completely loose body. So what's your diagnosis now?
Is there any history of discharge, sir?
No history of discharge. No history of discharge. Actually, we saw this patient about 6-7 years back. So, if I remember right, I don't think there was any discharge.
With the X-ray, what is your?
What is the diagnosis after seeing the X-ray? What is your anatomical diagnosis and what is your etiology?
Sorry.
Then Cholan.
Sir, it's Charcot's joint.
Yeah, it's consistent with
Charcot's joint.
good.
With
joint. Yeah.
with reactive new bone formation, sir. Tetrodotic ossification.
Okay. Can it be, you said the other diagnosis, no? Synovial pathology, is it possible?
No, sir. No, sir. Because article
Why? Why?
completely destroyed.
Can it be synovial chondromatosis?
No, sir. That looks like some calcification for
The main thing is this much of destruction you won't get. Synovial pathology, the main bone will be spanned, no? You might have multiple loose bodies and a snowstorm appearance, but the distal humerus, the proximal foramen will not be destroyed this much, right? So that is ruled out. And again, synovial sarcoma, mostly it is pertaining to the synovium, right? And can it be gout, pseudogout, metabolic, degenerative, destructive degenerative arthropathy? Is it possible? Can be. Can it be old sequelae of old septic arthritis?
Yes, sir.
Yes.
Any history of
No, the thing against this is only 6 months of so in a child, if they get any sepsis, this type of gross destruction can happen. After in adults, it's very, very rare to get this much of. So your first diagnosis is Charcot's is correct. This Charcot's joint. But one more try you want to give to know what is the etiology? Upper limb, common, sir asked, what is the common cause for Charcot's joint in the elbow, shoulder and the elbow?
Spine leather.
Only one cup.
Think of spine. Think of some spine problem.
Of some central. Yes.
Right, very good. Syringomyelia.
Yes.
So it's a case of, we think it is a case of syringomyelia with Charcot's joint because patient, we ordered an MRI of the cervical spine, but unfortunately patient didn't turn up after that. A very interesting case I put this, right? So Charcot's joint, you have to always, it's a rare thing, and dissociated sensory loss.
Yes.
You have to, it was actually not present in this case. That's why I didn't put it in the thing. A characteristic thing is dissociated sensory loss. Where else do you get dissociated sensory loss?
Tabes dorsalis.
Only left upper limb only.
Tabes dorsalis, right? And Brown-Sequard syndrome. Hemisection of the spinal cord. Rarely in diabetes, right? Hansen, we had a skin opinion also. They felt it can be due to the maybe cutaneous tuberculosis. They had advised a biopsy, but again, because patient didn't turn up, they said lupus vulgaris, a cutaneous form of tuberculosis. But unfortunately, the patient didn't turn up, so we couldn't have the full study. Hansen's, neurosyphilis, diabetes, all these things can cause Charcot's joint and causing repetitive microtrauma, joint restriction, and especially you have to look for ulnar nerve entrapment. And not take too much of time, but all these things you can read. So differential diagnosis, already as you said, you have to keep in mind osteomyelitis, septic arthritis, synovial chondromatosis, pseudogout, and synovial sarcoma. So usual investigations, how will you proceed to treat this patient in case he comes back? How will you proceed to treat this patient? What will you do? What is the order of investigations you're going to do? Yes, Cholan? Salvan?
Sir, first we have to rule out that things with syringomyelia, so MRI cervical spine.
Yeah, MRI of the cervical spine is to be done. Anything else?
Then to rule out other causes, to get that MRI of the elbow, sir.
MRI of the elbow, yes. If you feel there is any fluid, you can tap also. Study. Anything else? Routine blood investigations. Right? What is the final report? Biopsy. Yeah, biopsy has to be done. Both for the skin lesion as well as the elbow. Better to biopsy. And one characteristic of this Charcot's elbow is what we call as detritic synovitis, cartilage and bone seen all over in the synovium, which is characteristic for Charcot's of the elbow. So treatment is mainly supportive. Mainly you give NSAIDs, functional bracing. They usually do well with functional bracing and NSAIDs. Rarely they require because other treatment. If it is syringomelia, then definitely you have to do a neurosurgical decompression necessary. And some patients, laborers, coolies, they might require arthrodesis. Again, arthrodesis is going to be very difficult to achieve. You can, and elbow replacement is very controversial here. The picture of arthrodesis. And some words about syringomelia. Cystic cavity formation in the spinal cord. You should not forget the dissociative sensory loss of sensation in the hands, leading on to loss of digits, all those things. Can be congenital or acquired. Congenital, most common causes, they are Arnold-Chiari, okay, meningitis, tumor, and arachnoiditis. Any doubts?
Sir, one doubt from one candidate has asked one doubt, sir. So, is there any significance of the skin lesions with this problem? Because
we couldn't establish. That's what we couldn't establish because biopsy was not done.
So, suppose there is no syrinx. Suppose there is no syrinx. So then what is the second option, sir? Because clinically we cannot find out it's whether syringomelia.
Yeah.
So Charcot's joint is okay, it's a neuropathic joint, we accept.
Yeah.
But is there any skin lesion which is associated with the Charcot's joint?
That's what the dermatology opinion was, maybe a cutaneous tuberculosis. The other thing was, if you see carefully, this lesions are more on one side.
Yes, sir.
You see the more lesions pertaining to unilaterally. So maybe because of the decreased sensation, he had some injuries. And he had a susceptible tendency for keloid formation.
Yes, sir. Yes.
So cause this type of thing.
Sir, and one more doubt, sir.
You were sensation initially.
Yes.
Due to his work, he might have had small abrasions or small lacerations.
Which went for keloid.
Went on for keloid. That was one of their diagnoses.
Sir, and one doubt, sir.
One thing they wanted to rule out was lupus vulgaris, that is cutaneous tuberculosis. But I think this cutaneous tuberculosis will not cause this much of destruction in the joint. So I think it may not be.
Sir, and you were talking about distal neurovascular deficit, sir. Is there any significance of proximal lymphadenopathy in this case in a clinical examination?
Definitely, I have to look for proximal lymphadenopathy, especially.
So, was there any notes?
Notes were not there.
There were no notes.
No notes, no notes.
So in tuberculosis, there will be some matter or.
Pardon?
So if whether does that rule out tuberculosis if there is no matter lymph node?
Sepsis,
so can we say that tuberculosis we can exclude tuberculosis if there are no nodes?
Yeah.
And think more in terms of a neurological condition because there is ulnar entrapment.
Definitely neurological condition. Yeah.
Yes. Very interesting case, sir.
Yeah.
Very interesting case, sir.
Sir, having a skin lesion in this case, can we think of neurofibromatosis? Considering the skin lesion as neurofibromatosis, but it is, of course, it is unilateral, it restricted to
only. But neurofibromatosis look is not like the.
Exactly, look is not like that because PGs has
distribution is all over the body.
Yeah, exactly, sir. Exactly.
Dermatologists, they didn't commit. They said we have to do a biopsy. Their working diagnosis was cutaneous tuberculosis and skeloid formation.
Okay, sir. Very interesting case, sir.
Except this septic arthritis sequelae and syringomelia, none of the other.
Because this much of bone destruction. Yeah, that's true.
Sir, can we keep also PVNS pigmented villonodular synovitis as a option, sir?
Yeah.
Because you were taught once in our presentation, sir. A PVNS case will have lot of findings, but will have very less symptoms.
Yes.
So this case has got a lot of findings. Radiological has got a lot of findings.
Yes.
But patient is functionally not that much.
Not that much. That's why I didn't tell.
So can we have a pigmented villonodular synovitis also?
Yeah, definitely.
Yes, sir.
But Sir said the joint surface is grossly destroyed. It's almost lost. Both the distal elbow as well as.
Yes.
It is one point which is against.
Yes. So gross.
With long duration, then we can think of so much of erosion, distractor arthropathy, pseudogout, and all those things. It's only 6 months. So that is one thing against.
No, for only for differential diagnosis discussion.
Yeah, definitely we have to keep it. Yeah.
Yes, sir.
So I think you have to think of syringomelia as the commonest diagnosis. For low limb, now the diabetes comes into force. For ankle and foot, 15 years back, you think of leprosy. Now the diabetes has taken over the leprosy. So now the diabetes is the commonest cause, followed by leprosy. Knee joint, it is entirely different. The repeated intra-articular steroid injection by the quacks, that is the commonest cause, followed by diabetes.
Sir, in the case for the sir, as a postgraduate, what do you expect out of postgraduates? Because it's a very difficult case. So what is the minimum criteria for him to clear this case? So sir, what do you expect him to say?
So right now, because of you're not able to examine the patient.
Yes, sir.
If he says it is either a septic arthritis, a sequelae of septic arthritis, or Charcot's, or a synovial pathology, all three are acceptable, I think.
Okay, sir.
The skin lesions are not very classical. If it's classical, then Hansen and Charcot's will be the diagnosis.
Okay.
These three things we can accept.
So in Charcot's, what about the Ulnar intra? Is there a chance of ulnar palsy with Charcot's, sir?
Ulnar palsy is due to, yeah, definitely. Because of distraction, ulnar entrapment is very common in elbow. Charcot's of elbow. Ulnar entrapment, release of ulnar was described as a procedure.
Yes, sir. For sake of postgraduates, sir. So how common is Charcot's with associated with nerve entrapment?
Yeah, it's quite common, quite common.
There are some questions, sir. So what is the treatment? One postgraduate has asked, what is the treatment?
As I told you, as Thuru also already elaborated, the functional impairment is a little less and he's not having pain. You cannot go and give him a stiff elbow. He will not accept. So I think only NSAIDs and functional bracing and put him under observation and wait and watch.
Another question is, can neuropathic joint occur in tuberculosis?
Tuberculosis, I don't think so.
No, it don't occur.
It will not occur, yeah.
Not occur. Can we add a diagnosis of myositis sativans in this X-ray picture? Apart from neuropathic joint, can we add myositis as a sub-diagnosis?
No, definitely no. You see the amount of destruction of the normal bone.
There is a lot of abnormal mobility, so myositis sativans is a stiff condition.
Any other questions?
Is there any other questions you can put in the chat box so that we can clear it and go to the next case? You can give 2 minutes, sir.
Treatment wise, there is not much to offer. No,
not much to offer, la? Yeah.
Yes, sir. Better not to offer.
Total elbow பண்ணுவீங்களா?
கண்டிப்பா மாட்டோம்.
Even arthrodesis is not possible in this patient, sir. So much.
You will not accept. Being a plumber, even though it's the left side, you will not accept.
Only thing we can give a external supporting hinged brace.
Yeah, hinged brace. Some papers are there. I think total elbow, but I don't know.
Sir, Mohan sir wants to ask a question, sir. Sir, Mohan sir, நீங்க unmute பண்ணிக்கலாம் sir.
Mohan sir unmute பண்ணிக்கங்க.
Mohan sir unmute பண்ண முடியல நினைக்கிறேன். Jayesh, can you unmute Dr. Mohan?
Sir, Dr. Mohan is already on.
He's raised his hand, but sir has not asked any question. But he's just raised his hand, but he's not asked any question.
Now, Mohan sir, can you unmute? Hello.
Yeah. Okay.
Okay.
Here.
Mohan, any expert comments?
They're asking about villonodular synovitis. Adula vandu hand will not get involved and the thumb is discovered.
Yeah, naturally.
So it's another finding for neuropathic joint.
That's what. And the hand gives.
And because of insensate hand, I mean elbow, maybe a burns or any thermal injury would have caused scar much more. Without his knowledge, any burns or thermal injury would have caused much more scar for him.
Yeah.
Yes, because of loss of sensation, maybe he's got himself injured very frequently.
Mr. Jayas, can you unmute Dr. Singari Vadivel, sir?
There is one more question. Can it be a case of pseudoarthrosis from Bhaskaran?
Pseudoarthrosis due to what? Congenital.
Yeah. He is meaning trauma.
I don't think so.
No history of trauma. He's not had any history of trauma. Sir, good evening, sir. Singarvedi sir, good evening, sir.
Good evening. So,
good evening.
And I think when Samuel, when this case we saw.
Good evening.
Sorry, sir. For this case, I don't think after the X-rays, everything, other than neuropathic joint, if a candidate says anything else, after seeing the X-ray and clinical examination, probably before that, all those things is okay. Because septic arthritis without any history of discharge or bone getting so much destroyed without any ankylose or anything, it is very, very difficult to accept any of the other diagnosis. And the candidate, I wish that they
It's a
say...
differential diagnosis, you say, sir?
What is that?
No.
Or
Sir
is
wants to offer no difference.
diagnosis after seeing the
No
X-ray?
other. It's a classical case of neuropathic joint.
Yeah. So once you've seen the X-ray, then I think that they should not give any other diagnosis other than a neuropathic joint.
Sure, sir. After the X-ray, this is clinically we can think of this. Once they see the X-ray, definitely it's Charcot's. Yeah.
And yeah. And the second is for the candidate has to tell more about how they'll proceed to investigate this patient and how they treat the primary cause. So these are two things I wish to say.
Syringomelia.
Yeah, syringomelia or any other thing if they want to say.
Yeah.
And the skin lesion, as any thermal injury or anything which is the first, or the lupus vulgaris, it might be because a lot of times the added lymphadenopathy will be an added point for us. But if it is not there, we cannot rule out all those things, and then still we may have to think and do a biopsy and then treat the lesion.
But lupus vulgaris will it cause this much of joint damage? I have not seen a case.
No. That is separate. That is a separate thing. This will be neuropathic joint. That is super added probably. So other than neuropathic joint, I don't think there is any other diagnosis. So that's what I would say. Yeah. But it was very interesting discussion and diagnosis, Sam.
Thank you.
Brought out. Yeah.
Thank you so much. Very interesting case.
Any
sir.
other questions?
I think all the questions covered, sir.
Sir, any other treatment you'll offer for this?
No, apart from the bracing, because precision arthroplasty is one, and they'll not have any pain. There is abnormal mobility. So if they want
no replacements.
Brace. Apart from that, there is nothing else we can really offer. Because fusion, it is very, very difficult. People should understand that in a neuropathic joint, they must not be in a hurry to say about, because these are the things which will, leading question will ask whether you'll do a replacement, which is already discussed very well. So we must not say about replacement because the failure is very high because of there is no sensation. Second is fusion also, it is very difficult to achieve in these cases, very, very difficult. So a hinged brace and observation and diagnosing the primary cause. So these are the three things which I think we'll expect.
Thank you. Any other questions?
No other questions, sir. So thank you,
We
sir.
can move on to the next case, sir. Thank you for that very interesting case, sir, and a very difficult. X-ray பார்த்தப்பறம் it was fairly okay, but very interesting one, sir.
You can answer
Thank
your
you, sir. Suresh, நீங்க
very interesting, sir. Very interesting case discussion. I learned a lot of things, sir.
Thank you.
Sengarvel, sir. Good evening, sir.
Good evening, Suresh. Good evening.
Yes, sir. Yes.
Yeah.
Yes, sir. Sir, presenting the case of a 5-year-old girl child who had a trauma 1 year back and to the right elbow and treated conservatively from a...
Can I go through the history again, sir? Professor Sengarvel, sir, is here.
Okay, sir.
Hello.
Sir, you please go through, sir.
Can you hear me?
Yes, sir.
Hello.
Yes, sir. You are audible.
சுரேஷ் நீங்க ஆடிபிளா தான் இருக்கீங்க சுரேஷ்?
கேக்குதா?
கேக்குது நல்லா கேக்குது.
ஆடிபிளா? ஓகே. எனக்கு கொஞ்சம் ஆடியோ கிளியரா கேட்க மாட்டேங்குது. So this is a 5-year-old girl, history of trauma, right? Can I go through the history again?
Yeah, please.
சுரேஷ், yes, please. நீங்க சொல்லுங்க.
This is a 5-year-old girl, history of trauma, right elbow, 1 year back, treated natively. Now came with complaints of deformity of the right elbow. Deformity is not increasing, no functional disability. Clinical examination, there are obvious deformity, no warmth, no tenderness. Bone triangle is maintained. The thickening of the supracondylar ridges on both sides. Movement is minus 20 degree. That is 20 degree of hyperextension to 120 degree of flexion. No distal neurovascular deficit. Shoulder and wrist joints are normal. This is the clinical picture.
Now, Navneet, you can present the case.
So what is the name of the deformity? PGs?
Sir.
Navneet, you can answer the questions.
Okay, sir.
So what is the name of the deformity?
Cubitus varus, and the components are the varus deformity at the elbow joint, hyperextension, and the internal rotation, sir.
Okay. What is the other name for this particular deformity?
Gunstock deformity, sir.
So what is the normal carrying angle?
Normal carrying angle will be 8 to 15 degree usually. Okay. In cubitus varus, there will be 8 to 15, sir. There will be reversal of carrying angle in cubitus varus deformity. Hello.
You are audible. Proceed.
Okay, sir.
Suresh, you are audible. You are audible. He is also audible.
Proceed.
Normal carrying angle is the angle between the forearm axis and arm axis in a fully extended and supinated elbow. It should be usually 8 to 15 degrees, and in cubitus varus there is reversal of carrying angle, and it will become varus.
So, Navneet, the very common question Professor Samuel sir and Singadel sir usually ask: what is the reason for this carrying angle? Anatomical reason.
Sir, to clear the pelvis while walking.
Anatomically, what is the structure that is giving you the carrying angle? That they are very fond of that question, examiners.
Okay, sir. The medial distal end of
my
humerus.
audio is not clear.
Suresh, clear இருக்கீங்க Suresh? Your audio is clear.
அப்படியே எனக்கு கேட்க மாட்டேங்குது.
Your audio is very clear. நீங்க நல்லா கேக்குதே. நீங்க
பேசுறது எனக்கு விட்டு கேக்குது.
அப்படியே. அப்பனா உங்களுக்கு கனெக்ஷன் தான் ப்ராப்ளம். நீங்க பட் உங்க ஆங்க நல்லா கேக்குது உங்க ஆடியோ.
Okay.
Sir, medial trochlea is at a little lower level than compared to the lateral end of distal humerus, sir. That's why.
Okay, ma. Okay, proceed. Next question.
Okay, sir. Then diagnosis cubitus varus deformity secondary to malunited supracondylar fracture.
No. So what are the components of deformity you mentioned? Just a minute, I'll go through the slides.
Okay, sir.
So tell me how to assess the various components of the deformity.
Varus can be assessed by measuring the angle, sir.
Okay. Clinically, how will you measure?
I will draw a line that is axis of arm and axis of forearm, sir. Arm axis can be drawn by making intercondylar point at the elbow joint, midpoint of intercondylar.
No. Clinically, I'm saying clinically, how will you measure? Will you use anything to measure?
Goniometer, sir.
Normally we used to measure with
you are
use goniometer to measure the.
You are going to say how to take the midpoint of the arm and midpoint of the forearm.
Yes, sir. I'll select a point in the elbow joint, the midpoint of the line connecting the lateral and medial condyle.
So clinically, you can measure with the goniometer, both in the sagittal plane and coronal plane. Then how will you measure the deformity of transverse plane deformity, that is internal rotation deformity? Is there any special tests available?
Important question.
So this is the coronal plane and sagittal plane.
Okay, sir. I got your question, but I don't.
So how will you assess the internal rotation component of the cubitus varus deformity? How will you assess?
Or any other movements?
You check an elbow or any other joint?
Yes, sir. Shoulder internal rotation and external rotation I will measure, sir, and compare with the opposite side.
Okay. What is the name of the test? Is it?
Oh, Yamamoto. Okay,
Yamamoto's test.
Yes, sir. Okay, sir.
So you know how to do that?
It's I don't know the correct method, sir.
No, just keep the flexed elbow in the back of the over the back.
Okay.
Then you check the rotation, the amount of internal rotation. You understand, no?
Yes, sir.
You flex the elbow to 90 degree, internal rotate and keep the forearm over the back.
Okay.
Then you try to extend it with the shoulder and extension and elbow 10 degree flexion. Then you stress the shoulder to check the internal rotation available. So normally we don't get any internal rotation. So if we get a more internal rotation, then you measure the angle between the surface of the back and the forearm.
Okay.
So I don't have the clinical picture, but so the angle subtended between the back and the forearm axis.
Forearm.
So that is a amount of
internal rotation.
Internal rotation form. This is described by the Yamamoto et al. You can go through this article.
Okay.
So in X-ray, how will you measure the deformity?
Sir, I'll draw the axis through the humerus, that is through the arm and forearm, sir. Then I'll measure the angle, sir.
So what do you call? What is the name of this measurement?
Carrying angle, sir.
No. Okay, carrying angle. What is the name of this line?
You describe it in a radiological term.
Radiological term. You just mentioned in the radiological term. Any name for this particular angle?
From the
so you draw a line along the axis of the humerus, and then you draw the transverse line along the forearm bones. That is outer part of the radius and the inner part of the elbow. You draw two lines. You take the center point of this transverse line and connect this with a humeral line.
Okay,
so the angle subtended. What is the name of the angle? This is called humerus elbow wrist angle. That is called open impact angle. Sometimes the examiner will ask, this is a very reliable, most accurate angle to measure the carrying angle in the X-ray. There are many angles has been described. The humero-ulnar angle, metaphysio-diaphyseal angle. So this is a very most accurate and most reliable method. So only thing is we need to have a long entire upper limb X-ray, but here I'm not able to show the X-ray. So what is your clinical diagnosis from your history and examination? And what is your differential diagnosis?
Cubitus varus deformities secondary to malunited supracondylar fractures.
Okay, any other differential diagnosis?
Maybe due to congenital deformity of elbow or secondary to lateral condyle fracture.
Congenital deformity. Why congenital?
When you get a cubitus varus deformity in lateral condyle fracture?
Yeah, that is a good question. When will you get cubitus varus deformity in lateral condyle fracture?
Usually lateral condyle fracture will lead to non-union and secondary cubitus valgus deformity, sir.
Yes.
If there is hyperemia or over bony growth, it can lead to cubitus varus.
Yeah, only in healed lateral condyle fracture.
Healed lateral condyle.
So probably type 1 fractures. Or type 2 fracture which has been fixed with the percutaneous K virus.
Okay.
Which produces increased hyperemia and overgrowth. Similar to Caution's fracture of the proximal tibia.
Approximately.
You know what is Caution's phenomenon? Caution's fracture?
No, sir.
The proximal tibial metaphyseal fracture in children will cause a valgus deformity of the proximal tibia. The similar mechanism is due to increased hyperemia and the stimulation of the growth of the physis. Similar thing is observed. So why you wanted to mention it is congenital? Hello?
Yes, sir.
You told it's congenital.
Maybe.
Okay, which congenital deformity is common in pediatric in elbow?
Sir, congenital dislocation means radiolite dislocation, sir.
No, which is common. So radial ulnar stenosis, that's the commonest.
Radial ulnar stenosis.
Radial ulnar stenosis.
Okay.
So there is no possibility of congenital deformity here.
Okay, sir.
So your clinical diagnosis, what are the positive findings for to strengthen your diagnosis from the history clinical
Sir,
examination?
okay, sir. There is obvious deformity which is pain-free.
Okay.
That means it is and definitive history of trauma is there.
Okay.
So it has healed, and on examination there is cubitus varus deformity, and both the supracondylar ridges on both lateral and medial edges there is irregularity, sir. That means it may be supracondylar fracture.
Okay. Can it be due to the physeal injury? Physeal injury with the growth arrest. Is there any possibility?
But in physeal injury, there won't be any irregularity in the supracondylar ridges, sir.
Okay, sometimes supracondylar fracture extends into the joint, into the physis, some extension has been reported.
There is, okay, sir, a physeal injury, there may be a restriction of movement, or if it is intra-articular, there may be pain or a restriction of movement, sir.
More
Okay.
important is the triangle.
Anything else?
Yes,
History
sir.
also I mentioned.
Yes, sir. Three-point relation is maintained perfectly, sir.
Anything else from the history? What is the natural history of deformity in physeal injury?
He said it's non-progressive, no?
Yeah.
Yes, sir.
It is a non-progressive deformity. No, the mother says it is not progressed.
Okay, sir.
Because physeal injury is a progressive deformity.
Yes, sir.
From the clinical history also we can diagnose. So this is a malunited supracondylar fracture. So how will you tell in the exam? What is a complete diagnosis?
5-year-old girl child with a history of trauma 1 year back, now presented with a cubitus varus deformity secondary to malunited supracondylar fracture, which is non-progressive and with no neurovascular deficits.
Okay.
If I am getting the angle, I will mention the angle also in the diagnosis.
And also there is a restriction of the. Is there any restriction of movements?
Yes, sir. Restriction of external rotation.
No, I have not mentioned about external rotation. Which movement is restricted in this case?
Extension.
Flexion.
Flexion.
The flexion is restricted. Extension is increased. Okay.
Why is the flexion restricted?
Sir, it's actually there is no arc of movement is not changed, but there is hyperextension, so the total flexion is restricted, sir.
Yes. Okay. So supracondylar fracture malunion is the commonest cause of the cubitus varus deformity.
Okay.
What is the reason for the malunion cubitus varus deformity in this particular fracture?
Sir, supracondylar fracture, most common type is extension type, sir. Fall on outstretched hand may be the mechanism. And at the time of injury itself, there will be extension, that is a posterior translation and posterior tilt of the distal fragment.
Okay.
As well
what
as
is the reason for varus? Why varus deformity is more common in supracondylar fracture? In other words, what displacement causes varus deformity?
Medial displacement and internal rotation deformity, sir, due to the pull of biceps.
The medial displacement, the medial tilt is the main cause of the varus deformity.
Okay, sir.
This corresponds to the amount of deformity. The medial rotation does not cause much of the deformity, but medial rotation decreases the bony contact surfaces on the
lateral
medial side. So it becomes unstable because of the medially rotated and decreased bony contacts. That increases the medial angulation. That adds to the varus deformity. The main thing is we have to correct the medial angulation. So sagittal displacement causes hyperextension deformity. What are the other causes I told you? So lateral condylar fracture, which produces hyperemia and stimulates the growth, especially the type 1 or type 2 fractures. The type 3 and neglected fractures produces valgus deformity. Again, the malunion of the medial condyle intercondylar fractures can also cause the varus deformity. And medial condyle non-union, very rarely, medial condyle non-union can also cause a cubitus varus. Then physeal injuries with medial growth arrest can cause a varus deformity. Very rarely, AVN of the trochlea. Sometimes after the supracondylar fracture, sometimes idiopathic without any reason. We can get a avascular necrosis of the trochlea. Can cause a progressive deformity. In the next two conditions, it is always a progressive deformity. Physeal injuries in AVN trochlea, we get a progressive cubitus varus deformity. So what type of deformity you will see in the X-ray in avascular necrosis of trochlea? In the X-ray,
fishtail deformity.
Classical fishtail deformity you see it in the X-ray. So these are all some of the reasons for the cubitus varus. So infections, tumors, and if you see a bilateral cubitus deformity, varus deformity, think of skeletal dysplasias, especially the epiphyseal, multiple epiphyseal dysplasias, caudal epiphyseal dysplasias, and multiple hereditary exhaustosis can cause a bilateral varus deformity with a radiated subluxation or dislocation. So you have to differentiate between the progressive and the non-progressive deformity. The treatment of both these conditions is completely different. So what is investigation you will order in this case? What investigation you want?
X-ray of elbow joint in both AP and lateral views.
You want only the one side or the other side also?
Other side also, to compare the normal carrying angle on the other side.
Okay. So full length X-ray AP of the both upper limb and lower limb. So I am not able to give you the opposite limb. This is a right upper limb X-ray. So what will you see in the X-ray?
So I'll measure the angle in the X-ray.
X-ray shows obviously there is a cubitus varus deformity.
Cubitus varus, okay,
yeah.
sir.
Then you will measure the lines.
Lines. I'll draw the lines and measure the angle, sir, and I will measure the correction.
Femoral elbow, wrist angle.
It is Cora.
The AP view.
Okay.
Then what will you see in the lateral view? You have to take a true lateral view of the affected elbow. So what will you see in the lateral view?
Sir, anterior humeral line will not be passing through the capitulum, sir.
Yes. Anything else you see? So normally anterior humeral line will go through the which part of the capitulum?
Anterior 1/3 and posterior 2/3 junctions, yes, around.
It goes through this, almost go through the center of the capitulum.
Center, okay.
So what is the other radiological sign you see in this X-ray?
Hourglass appearance, sir. If it is a proper lateral view, hourglass appearance should be.
You can see a overlapping of the
crescent sign, sir.
Crescent. So when you say overlapping of the
overlapping of the capital into the olecranon.
Olecranon. So normally we don't see the overlapping in a true lateral view. This X-ray is not true lateral, but you will see that indicates there is a tilt of the distal.
Distal humor.
Okay. So what else you do after seeing the X-ray? So planning for the treatment.
Yes, sir. I'll measure the correction, sir.
Yeah. What is the amount of correction? How will you calculate the amount of correction?
Normal valgus on the other side I will measure, and I will add the amount of varus in this side.
Oh, okay. So you draw it in the tracing paper. So angle of correction is the varus deformity on the affected side plus the normal carrying angle. So that is the amount of correction. So you need. So you know how to do the preoperative planning, no? So what is your plan of management? What will you offer for this particular child?
If they want correction of the deformity, we can do corrective osteotomy, sir.
What is the indication for surgery in this case?
If the patient and parents are concerned about the deformity, sir. In this case, it is not progressing. There is no neurovascular deficit.
I want to tell the word cosmetic.
Cosmetic, sir. Okay.
Cosmetic is an indication in this particular case.
Okay.
So when will you advise surgery? Now the child is around 6 years. The injury happened 5 years back. Now 6 years. When will you advise surgery? Is there any time duration? Is there any time limit? Is there any age?
Sir, 6 to 10 years is the maximum remodeling of distal humerus, sir.
Yes.
time for maximum. So better to do it after.
Will the varus deformity remodel with the growth?
No, sir.
Will it remodel with the growth?
Why?
You only said it will remodel from 6 to 9 months. So 6 to 9 years.
I don't think it will get fully normal, sir.
What is the normal tendency is to go for normal anatomical carrying angle.
Yeah, yes, sir.
That means it will remodel, la?
Okay.
Up to some particular age.
To some extent, okay. Okay, sir.
So the varus deformity will not remodel with the growth. Why it will not remodel? Because the fractures happen in children. Why the varus deformity will not remodel with the growth? Any particular reason?
I don't know, sir. I don't know, sir.
What is the percentage of growth around the elbow? The distal humerus. What is the percentage of growth in the proximal humerus? So the proximal humerus is 80% growth, the distal humerus is 20% growth.
Okay, sir.
So what is the principle of remodeling? The deformity in which plane will remodel better? These are all standard basic principles. The deformity in which plane will remodel better? Hello?
Yes.
He doesn't know, Suresh. You have to
Okay.
Suresh, நீங்க continue பண்ணிடுங்க Suresh. Just you can go and answer the question.
Continuously.
The deformity in the axis of movements will remodel maximum. And the deformity around the joints, around the bone, where the growth potential is very high, will remodel. So elbow has got a very less growth potential. Only 20% of the growth is available in the elbow. And moreover, the varus deformity is perpendicular to the axis of the elbow movements. Because elbow movements is happening in the surgical plane. This is almost in the perpendicular axis. The varus deformity is perpendicular to the axis of the movements of the elbow joint. So normally this deformity will not remodel. So that is why the hemiepiphyseal disease is not indicated.
Okay, sir.
You know what is hemiepiphyseal disease?
Yes,
It's called growth modulation concept.
Yes, sir.
You have to put the
Gated
now
growth.
recently we have an 8-plate available, so you have to
Yes,
put
sir.
the 8-plate on the lateral side.
Lateral side, okay.
But this is not applicable in this particular deformity because of the growth potential is very, very less.
Okay, sir.
But only one condition where the hemiepiphyseal disease is useful is if there is a physeal problem with the progressive deformity. Even if you do a corrective osteotomy, it is going to recur. So in that particular case, you can do the osteotomy and then you put the lateral side, the 8-plate. You do the hemiepiphyseal on the lateral side along with the correction of the deformity, so that you are holding the growth on the lateral side so that we can prevent the recurrence of deformity till the growth maturity. So otherwise, hemiepiphyseal disease is not used for the normal supracondylar fracture where the growth rate is normal. Another suggestion: can we avoid surgery if there is cosmesis is not a concern to the child? Suppose the parent says became the deformity, they are not willing for surgery.
Yes, sir.
Now simply the complaints only of cosmetic reason. So will you say that, what is your advice?
Is there any potential risk to this cubitus varus?
So in other words, what is the long-term consequence of cubitus varus deformity if you don't treat? Is only functional issues? Is only cosmetic or are there any functional issues?
Sir.
Yeah, a lot of functional issues are available. So Nostril inactivity is not advised because it causes long-term functional complications. The corrective osteotomy is the only option which gives a very good outcome. So what are the long-term problems? One is tardial ulnar palsy. The reason for tardial ulnar palsy is
recurrent subluxation.
Recurrent subluxation and the compression of the now by the medially displaced triceps in the cubitus varus deformity. The compressive neuropathy. Again, posterolateral instability also been reported. Snapping of the triceps medially. First fracture are there, distal humerus, lateral condyle fractures, lateral epicondyle fractures, bicycle injuries, and have limitation of sports activities like difficulty in push-ups, swimming, throwing, and also the severe varus deformity. The person always keep the shoulder in internally rotated position. It causes shoulder instability also. So the cubitus varus deformity is not only the cosmetic, it has got a long-term functional implications also. So you have to counsel the parents that the deformity needs to be corrected, especially if it is a progressive deformity. All this progressive and severe deformity. If it is a progressive and severe deformity, the chance of all these complications are there. So when will you intervene? When will you advise surgery? I think I already told, you mentioned, I think, between 6 to 10 years. But very important is you have to wait for the complete fracture remodeling and full recovery of the movements. The child should get a full extension of the elbow. If there is a flexion deformity of the elbow, you should not do it. Don't do it when the child is having flexion deformity. Why we should not do it? Hello?
Don't know, sir.
Because only in full extension you can assess the carrying angle. So you cannot assess the carrying angle in a flexed elbow.
Okay.
And also you would wait for the complete fracture remodeling. The metaphysis should completely remodel so that you can plan the appropriate wedges and appropriate osteotomy. If you do it early, there will be a lot of callus and bone is thickened. Then your wedges and everything will be inappropriate. So you have to wait at least for 1 year, minimum 1 year. And also another reason we are waiting for 1 year, because you can rule out a physeal injury. Because you can rule out, you can document the amount of deformity, and also you can make sure the deformity is not progressing. If you document the deformity is progressing over a period of time, then probably you have to rule out the physeal injury in addition to the supracondylar fracture, or sometimes avascular necrosis of the trochlea also. So it is not necessary to wait till skeletal maturity, because previously we used to thought that we have to wait for the maturity. The deformity will recur if you do it early. So wait for at least 10 years and 12 years and do the deformity correction once for all. But it is not necessary to wait till skeletal maturity, because the supracondylar fracture deformity, varus deformity, it is not a growth plate problem. It is a malunion. You can correct it as early as possible. Ideally around the age of 6 years up to 10 years, because between 6 to 10 years, what you mentioned is correct. Between 6 to 10 years, if you do a corrective osteotomy, if there is any residual deformity like sagittal plane deformities, if there is a bony prominence on the lateral side, all these things will remodel with the growth. So you can correct only the coronal plane deformity if you are doing in the early age groups. No need to correct the sagittal plane deformity completely, because it will remodel with the growth. But if you are doing the surgery after the age of 10 years or 12 years, you have to correct all the both coronal plane and sagittal plane deformities. Rotational deformity is always a controversy whether to do it or not. And also in more mature children require more robust internal fixation like plating and other things, because of the healing potential as well less in this older age group. So where is the Cora? How will you measure the Cora in this particular case? Hello?
Sir, Cora is the, in a deformed bone, we have to write an axis in the proximal segment of the deformity as well as in the distal segment of deformity, and the intersecting point will be the Cora.
So where is the Cora now?
It
is exactly the
olecranon fossa.
So ideal surgery is at the level of the Cora.
Okay, sir.
So here, where will you want to do the surgery? Suppose if you are advising surgery.
Above olecranon fossa.
So above the level of Cora, you have to do it above the olecranon fossa.
Yes, sir.
So what is your osteotomy principle? What is the basic osteotomy principle you will apply in this case?
Lateral closing wedge osteotomy, sir.
Okay.
If we have to measure the amount of correction earlier itself, and 1 mm of bone will correct 1 degree, sir.
No, that calculation is not useful. So 1 mm bone is equal to 1 degree. It's not useful. So you have to make a template with some X-rays and you make it sterile, and you have to overlap on the bone, and you take the wedge. Appropriate. It's not the 20 degrees equal to 2 centimeter.
Okay.
So the cora is exactly the olecranon fossa, but where osteotomy is doing away from the cora, so it is always should be the distal fragment should be translated to avoid the secondary deformity. Otherwise, it will cause a secondary lacy S-shaped deformity. That is what we will see in all the supracondylar fracture karate osteotomies. There is a lateral bony prominence and a secondary deformity. Okay. So you have to avoid the lateral bony prominence and secondary deformity by translating the distal fragment.
Medially translate, sir?
Medially. Translate the distal fragment medially.
Okay, sir.
But problem is the translation of distal fragment medially will make the osteotomy be very unstable. So you have to do the rigid internal fixation. So this is severity grading. Some examiner will ask, what is the severity grading? So grade 1 is the loss of facial angle. Grade 2, 0 to 10 degree of varus. Grade 3, 11 to 20 degree of varus. Grade 4 is more than 20 degree of varus deformity. So what are the types of osteotomies, you know? So lateral closing wedge osteotomy is the simplest. So very easy to do it. Less soft tissue dissection. Then medial opening wedge osteotomy, it is associated with more neurological complications because you are lengthening the medial column. Zoom osteotomy, oblique osteotomy, derotation. This is oblique osteotomy similar to oblique osteotomy at the proximal tibia. We do it for a Blount's disease. Have you heard about RAB osteotomy? It is oblique osteotomy which will correct all the three-plane deformity. Similar osteotomy has been described here to correct all the three components of the deformity. Step cut osteotomy, spike osteotomy, pentalateral. So I have put the simplest osteotomy, the lateral closing wedge osteotomy, simplest. If you go from proximal and downwards, the osteotomy becomes more and more technically demanding. So coming to the approaches, what are the approaches, you know? The lateral approach, the simplest approach, less dissection, very good exposure. Only thing is scar. The scar is very visible. Sometimes hypertrophy scar. So you have to be very careful about the scar. The medial approach for the medial opening wedge osteotomy. Only thing you have to take care of the ulna now. You have to transpose the ulna now. And posterior approach is more useful. It is a more extensive approach because you have to take down the triceps, and it is more useful for the complex osteotomies like a step cut osteotomies, pentalateral osteotomies, all reverse cut, dome osteotomies. All these osteotomies we can do the posterior approach. So these are the type of fixation. Lateral K-wires, cross K-wires, K-wires with the tension band wire. This is a French technique. Two screws.
Screw with the
tension band wire.
Stainless steel wire.
Stainless steel wire. Two screws. It's a bicortical screw.
Okay.
So this is a plate fixation. Ilizaro, AO mini external fixators. Combined technique. You see the K-wire along with the
screws.
Tension band.
Tension band wire.
The K-wire is also used along with the two screws and tension band wire. The combination of this is also a combination of the two techniques. So younger the age groups, you can go for simple fixation. Older the age groups, you have to go for a more stable fixation like a plates and external fixation. So is it necessary to correct the? So we are all very happy. We will correct the coronal plane deformity, the cubitus varus deformity in the coronal plane. So is it necessary to correct the other deformities like internal rotation deformities and extension deformities? This is a very important paper published by JBJ. They mentioned that the extension deformity remodels if the age is less than 10 years. And the correction of rotation in osteotomy leads to less bony contact between the osteotomy sites, and it makes osteotomy very unstable. So we are likely to lose the correction. And also, the rotation will cause an anterior bony bump, which will limit the further flexion of the elbow. So moreover, the internal rotation deformity is well compensated by the shoulder movement. There is no long-term functional consequences have been reported because of the internal rotation deformity. They concluded that there is no need to correct the rotational deformities. And the sagittal plane deformities you correct if the child is more than 10 years. Otherwise, you leave it, it will remodel to a certain extent the growth. You can correct minimal extension deformity, but it's no need to correct fully. So this is a lateral closing wedge osteotomy. It's very simple. Can I go through the slides, sir?
Yes, sir. Yes, sir.
Hello.
சுரேஷ் சுரேஷ் கொஞ்சம் ஃபாஸ்டா முடிச்சலாம். இன்னும் ஒரு கேஸ் வேற இருக்கு. அந்த கேஸ் கொஞ்சம் ஃபாஸ்டா முடிச்சிட்டீங்கன்னா கொஞ்சம்.
Lateral closing wedge osteotomy is very simple. So the two techniques, the French and modified French osteotomies, other one is equal limb oblique osteotomies and lateral oblique osteotomy. I will go through the technique. So what is the difference between the French and modified French is, here the very important difference is the French osteotomy medial cortex is broken. Here medial cortex is intact, stable. It acts as a hinge in modified French osteotomy. So other things is it is posterior approach, it is posterolateral approach, it is prone position, it is supine position. So very easy to assess the correction. Here osteotomy is fixed with the screws and tension band wire loops. The rotation can be corrected if necessary by offsetting the two screws. You can see here modified French osteotomy. It is a lateral closing wedge osteotomy. The medial cortex is intact with the periosteal sleeve. It is act as a hinge, so that you can put a tension band here. You offset the screws, distal screws anteriorly and proximally posteriorly. Then you tighten it till the screws. You can leave it like that. You could tighten it till the screws become parallel, so that we create a external rotation deformity of the external rotation of the distal fragment will correct the internal rotation deformity. The intact this hinge on the middle is very, very important. Then only the tension band principle will work. If it is broken, then if you tighten this loop, it will open up on the other side and become unstable. So this is very, very important. So suppose when you see that it is broken, then probably you can combine the fixations. You put a tension band and put a screw K-wire also. As I mentioned earlier, you can combine the two techniques. Put a K-wire and put a screws and tension band if the medial cortex is broken during the surgery inadvertently. This is the example, French technique. The only problem is here is the lateral condylar prominence. Because of the medial cortical hinge is intact, we are not able to translate. So that is why it causes the lateral condylar prominence. Another problem is sometimes the screws will pull out and loosening and loss of reduction. So again, it needs an implant removal at a later stage. So if you are worried about the middle cortical hinge is gone here, so we can pass a K-wire and add the tension band wiring principle. So to avoid the lateral bony prominence, there are two techniques have been described. One is a equal limb lateral closing wedge osteotomy. The osteotomy is done. It is like a isosceles triangle with the two equal sides. So this triangular wedge is preoperatively cut in the X-ray film, and then it is placed over the supracondylar area, so that the osteotomy on the proximal and the distal osteotomy is almost equal in length. You take out the bony wedge and close it, so it causes less lateral condylar prominence. And also there is a more contact bony surface area for the healing. You can fix it with the small K-wire. You can use a threaded K-wire instead of a smooth K-wire if you are worried about the K-wire pulling. So what we follow in ICH, this is a surgery done for the particular case I showed in the clinical picture. So we use a lateral oblique closing wedge osteotomy. It's similar to equal limb osteotomy, but slight modification. So we all supine position into lateral insertion, the preset K-wires. So this is a K-wire for the fixation. This is a K-wire inserted in an angle, desired angle of correction. This is the amount of correction required. The K-wire is inserted just at the proximal end of the olecranon fossa, directed medially just above the medial epicondyle. Then another wire proximally at the desired angle, which converges the distal wire. Then I pass one more wire in the proximally. It acts as a joystick wire to help in closing the osteotomy site. Then osteotomy is done with the oscillating saw. You see the medial cortical matrix is not broken here. Usually I use osteotome to break this, so that the hinges, periosteal hinge is maintained. Then close the osteotomy. See, if we close the osteotomy, automatically it will cause us a translation. Because in this oblique osteotomy, so this osteotomy, this length is more than the distal cut length. So automatically it causes a translation of the deformity with the intact medial hinge. Then you just pass the preset to 2 K wires. It's very stable. You can see that lateral alignment also is restored. Post-operative X-ray, the clinical picture, and the follow-up. This is a 6 months follow-up. So all is some bony prominence and some sagittal correction is required, but it will remodel with the growth. So middle opening with osteotomy described by King. Usually
Suresh, நம்ம next case போயிடலாம் சுரேஷ்.
போயிடலாமா?
Okay.
The middle opening with dome osteotomy, closed dome, step cut, all this. There are multiple techniques available. So I want to know what is pseudocubitus varus deformity. This is an exam question. PG's pseudocubitus varus deformity. It is a deformity in a lateral condyle fractures because of the lateral condylar bony spur formation due to elevated periosteum on the lateral side. It causes a newborn formation, spur formation. It produces apparent varus deformity. The clinically carrying angle is normal. This is called pseudocubitus varus deformity. So normally all this bony spur on the lateral side will remodel with the growth. No need to do anything. So I'll go to the second case.
Thank you, sir.
Other PG can present the second case.
Suresh, இது கொஞ்சம் rapid முடிச்சிடலாம். Just like a short case. I know you can go on and go on. I can understand. I think sir Singaradil sir, நீங்க உங்களுடைய சாரோட comments.
Sir, any points to be added in the cubitus varus, sir?
Very exhaustively taken, and as an examiner I cannot ask any more questions, and I learned a lot. Thank you, Suresh.
Thank you. So probably we can give another special session for Suresh sir.
Yes, sir.
Talk about
Fantastic.
2-3 sessions.
He can go on. அவர் போயிட்டே இருப்பாரு. எங்கயா ஸ்டாப் பண்ணிரணும் அவரை.
Correct. Thiru, what he is doing is right.
Vignesh can present the second case. Yes, you start presenting the second
case. So this is a 9-year-old child. I think he had an injury of the elbow, and I think clinical examination showing in the antecubital fossa.
Suresh, we'll ask the PG. நீங்க அவன diagnosis மட்டும் கேட்டேன்.
Straight அங்க போய்ட்டோமா? Okay.
So we will discuss with them with the diagnosis, then you can go.
Vignesh is here.
Sir, yes sir, I can hear it.
Yeah, you coordinate.
It's a 9-year-old male child.
Yeah.
Presenting with no obvious functional difficulty in movements. So with the prominent swelling over the anterior aspect of the elbow, sir. So the probable diagnosis, I like to give a differential diagnosis for this, sir.
Okay.
My primary diagnosis would be myositis ossificans, and secondary would be a neglected Montagia with anterior dislocated radial heads.
So why you are telling about the myositis ossificans?
Sir, because 8 months back there was a history of trauma,
okay.
And the deformity was progressing, but now it has come to a stop, sir. It is not progressing now.
Okay.
After and the pain is also subsided, and the patient is only having some range of motion difficulty in the final degrees, final 30 degrees.
So in history, what is your any history supporting your myositis ossificans?
So only the history of trauma, and the patient was normal after putting him on above elbow slab, and there is a swelling, sir. And the 3-point bony relationship is maintained. So
actually there is no history of massage or nothing was done in the pre-operative. The child was treated with a POP for 3 to 4 weeks.
Yes, sir.
And also the swelling.
The swelling moves with the moves with the rotation. So it is a radial head.
I told it is very smooth and rounded. It is moves
with the pronation and the supination.
And also the other movements are almost nearly full.
Yes, sir.
The flexion extension is full. Only the flexion is restricted.
So the anterior is.
So I don't know, sir.
No, myositis
ossificans is acceptable, huh?
No, because we have not given him a case. No, we only given him a scenario. So definitely we can accept his diagnosis. If we had given him a clinical case, and then maybe he could have, found out.
Only point against it is moving with the movement of the
only the moving is.
Yeah, no, he is given only a differential diagnosis. So he is given Montague also. I think we have to accept his findings.
Okay. So what will you do now?
So next is I will take X-ray of the patients.
Okay, this is X-ray.
This is a plain X-ray, AP and lateral view of a child, which is not skeletally mature. showing on the lateral side, I can see the dislocation of the dislocated radial head and also the bowing of ulna. Sir. The bowing seems to be more on the lateral side. So it confirms the diagnosis of neglected Montague, which is malunited neglected Montague.
Any findings in the AP view?
Sir, AP view, the radial head is not in.
What deformity he has mentioned in clinical examination?
The valgus deformity, sir. I can see the
I
cubitus.
don't have the full length X-ray. I think there is some valgus deformity.
Valgus
also
deformity.
in the proximal ulna, we can see some angulation.
Yes.
Minimal angulation of the proximal ulna in the AP view also. So what are the radiological signs?
So there is a bowing of ulna, sir, which is more than 1 centimeter when we draw a line from the olecranon to the
What is the
distal.
name of the line?
Actually, I'm not sure.
Mubarak.
Mubarak
Line. So what is the name of the sign?
Ulnar bow, sir.
Ulnar
Plastic
bow
deformation. Ulnar bow.
Ulnar bound sign.
More than 1 mm.
It indicates there is a plastic deformation of the
Deformation.
ulna. So what is the other radiological sign?
Dislocated radial head.
Radial head. So here it is very obvious. But suppose if it is a subluxation, so any other radiological sign?
Yes, sir. We have to draw a radiocapitular line, sir, which have to bisect exactly at the capitulum at any position of the elbow.
Radiocapitular line, irrespective of the position of the elbow, it will go through the center of the
capitulum.
So the radiocapitular line and the ulnar bow sign, Mubarak line, ulnar bow sign. So all these both signs are positive here. So it confirms the diagnosis of a. So what is the diagnosis now?
It is a case of neglected Montague, sir. Neglected Montague, malunited fracture.
So what type of Montague fracture?
It is a Bardo type 1 type, sir.
Type 1.
With anterior dislocation.
Because adult type 1 is different and pediatric type 1 is different.
Yes.
So in pediatrics, how will you mention this type of deformity?
Any special name?
So no, sir.
Because Bardo's classification is modified. The modified classification, I think the name I will mention later. It is a plastic deformation of the radius with the anterior dislocation. So another type is a green stick fracture, unicortical complete fracture and posterior dislocation. I will explain it in the later slide. So this is a missed Montague fracture. So what is the natural history? What will happen if you don't treat this condition? So how will you manage this particular case? Will you operate or not?
Yes, sir. We have to operate the case because there is a progressive valgus. The valgus is progressive because of that. There is no radial restraint on the lateral side, sir.
Okay.
So and there is also difficulty in functional range, sir. Up to 30 to 130 degrees functional range, sir. So the functional range is also decreasing, sir.
So
we have to definitely.
Movements, it is non-functional, and there is a valgus.
Valgus, progressive valgus.
So we have to ideally to treat. If we don't treat, what will happen?
Tardial ulnar palsy because of the valgus
will progress. They get tardial ulnar palsy. They get restriction of movements.
Yes.
They get instability of the elbow. They get pain. They get late arthritis. All these complications will develop. So if we don't treat, these are all the complications.
Sir.
Distal radial ulnar joint subluxation and positive ulnar variance also one positive. Late neuropathy and arthritis. So how will you manage this case?
So manage this the deformity is progressing right now, so we'll opt for surgery. So first I will take a lateral view and look at the alignment, sir. Then I will do osteotomy of the ulna, sir, first.
Okay. So the basic pathology is that
ulnar, the ulna, sir. Ulna. So after reduction of ulna, I have to look for the residual subluxation or the radial head has reduced already, sir.
Okay.
If it has not reduced, then I will go and clear the.
You go for a open reduction and remove the what soft tissue interposition will be there.
Fibrous tissue.
Annular ligament interposition and fibrous interposition. You have to remove all the fibrous tissue and annular ligament into position, then it will reduce.
Yes, sir.
So basically, you have to do the osteotomy,
Of the
restore
ulna,
the
under length of the
and
radius.
angulation, and also you have to create a slightly more opposite angulation to reduce the radial head stably into the over the capitulum.
Yes.
So the stable reduction is the main aim of the treatment. So the principle of surgery is they have to correct the shortening and angular deformity of the ulna is a fundamental. Once you correct the ulnar deformity, the radial head automatically reduces indirectly by the traction of the interosseous membrane. So you correct the deformity, the traction will causes an indirect reduction of the radial head. So location of the osteotomy is controversial. So again, the location of osteotomy is most commonly we do osteotomy at the proximal and metaphysis. That is at the junction of the proximal 1/3 and the distal 2/3 of the deformity. Then you have to create the angulation the opposite to the direction of the radial head. Suppose it is anterior dislocation, you have to create the slightly posterior angulation at the osteotomy site. Suppose it is a lateral dislocation, then you have to create the medial angulation of the ulna. You will see in a type 3 fracture. Then bone grafting is again controversial. If you need a more than 10 mm of distraction, probably you need bone grafting. But many literature says even if it's more than 10 mm of distraction, there is no need to do any bone grafting. It heals in a children. Type of fixation, you can go internal fixation with patent screws, external fixator, cross cables, intramedullary wires. But all these fixators, K wires are cumbersome. Internal fixation is a very preferred technique because so we can contour the plate. It produces more rigid and stable internal fixation so that it will locate the radial head stably over the capitulum. So the options of treatment is angulation, distraction osteotomy is the plating, sliding osteotomy, and external fixator restoration. This is sliding osteotomy mentioned in the Ganga hospital. Here they do that like Z lengthening of the ulna. So this is a very complete osteotomy. You slide it and you angulate it and fix it with a lax screw. Then you reduce the radial head. This sliding osteotomy. External fixator assisted osteotomy. Here the external fixator is applied, slow distraction is done till the radial head reduces. This is a few case reports about the external fixator assisted gradual reduction. They mentioned that there is no need to open the radial head. So they have reported that the radial head reduces spontaneously, but most of the other literature says they need a open reduction and remove the soft tissue interposition in most of the cases. This is only case reports. Again, external fixator assisted osteotomy. So you can do external fixator, slowly distract and angulate. Then once the radial head is reduced stably, then you plate the osteotomy, then remove the external fixator. It is external fixator assisted osteotomy. For our management, we had an angulation distraction osteotomy in the supine position. We use the White's approach. Transverse osteotomy is done. You go through this. This is a intraoperative picture. We went through the White's approach, opened the radial head and the elbow joint and removed all the fibrous interposition. Then the incision was extended distally to expose the ulna. Osteotomy is done and is slightly angulated and fixed with a contoured plate. You can see the posterior angulation. The amount of posterior angulation you can decide on table. After reducing the radial head, you remove the interposition, you reduce the radial head, you temporarily fix with the K wire. Then you create the angulation of the ulna. You contour the plate and fix the plate. Then you can take up the radiocapital K wires. Don't leave the radiocapital K wire because most of the times it breaks in the postoperative period and very difficult to retrieve the wire. It's only temporary K wire to assess the amount of angulation required at the osteotomy. Very important when you are doing osteotomy, always mark the proximal and distal osteotomies because we should not create any rotational deformities after doing the osteotomy. So mark the surfaces, either with the drills or you can pass small K wires. So make sure that you are not causing rotational mal-alignment after the osteotomy because that will restrict the forearm rotation. So that is the one clinical error we do during the surgery. So you have to be very careful. This is the immediate postoperative period. You can see the radial head is completely reduced. This is the angulation osteotomy. The bone graft is done in this particular case. 1 month post-op, 2 months. This is the follow-up, the full range of motion. So can I go through the slides or we'll stop?
Sir, And in the case theory ரொம்ப வேணுமா sir? Sir, shall we go ahead, sir? Singarodil sir.
How long it will take,
No,
sir?
I'll go to the last question only. So
Okay,
after the
okay.
management, how to prevent this condition? The PGs, how will you avoid this particular condition?
Sir,
Why it is missed? Why this fracture is missed initially?
because of the lateral view, we have to see the lateral view properly, sir, for any subluxation of the radius from the
Probably
elbow.
the
Sir.
initial surgeon has not seen the X-ray properly. That is one reason.
Because
So
plastic
you have to-
deformation might be missed.
So you have to recognize the plastic deformation. You have to recognize the radiocapital alignment. So very, very important. Any isolated fracture of the ulna, so you have to carefully look it in the radiocapsular joint. So if you see this particular fracture acutely on day one, what will you do?
Sir, I will try to closely reduce and definitely internal fixation must be done, sir.
Oh, no need for internal fixation in all the cases. If it's a plastic deformation, you reduce it under anesthesia
and
you
check for
create two
radiocapital.
towels on the either hand. You two towels on the either side. One is elbow, one is in the, around the wrist, and you create a pressure. You create a posteriorly directed pressure over the ulna. Then you correct the deformity of the ulna. Then it will automatically reduces the radial head. Then you have to immobilize in which position?
Sir, supination, sir.
Full supination.
Full supination.
And what degree of flexion?
Same 90 degrees flexion.
It's not 90 degree flexion is very unstable situation. You have to put it in a 120 degree of flexion. Full supination and 120 degree of flexion. So what complications do you have to observe if you are putting in a supination and 120 degree of flexion?
So because of any vascular compromise, you have to look
So
for
you have to
pulses.
look for the Volkmann's ischemia. That is the one problem. So you have to carefully look for that. Always it's better to open the antecubital fossa and you keep the splint only on the posterior aspect.
Posterior, sir.
If there is too much of swelling, probably you can go for internal fixation. If there is a displaced fracture, suppose if it is a oblique or displaced fracture with a radial dislocation and acutely, you can do internal fixation either a percutaneous solid K wires or thin rush nails.
Yes, sir.
And you don't need a flexion more than 120 degrees.
120 degrees.
So you can keep it in around 90 degrees so that it will not cause any
Volkmann's
impact. So don't miss the diagnosis. That is the lesson. You have to look for the radiocapital line in all the X-rays. This is a reduction under anesthesia. In this particular case, because a lot of swelling is there, we put a percutaneous intramedullary K wire, so we kept it in less than 120 degree of flexion. But ideally, if you are not putting implants, you have to put it in 120 degree of flexion.
120 degrees of flexion.
I think it will. Can I stop?
Yes, sir.
I think we'll stop this particular moment. Hello.
Suresh, yes,
Thank you, sir.
Okay.
You can unshare your screen, sir.
There are a lot of slides available about this thing. I'm not going.
Suresh, we'll give you Suresh. I mean, our Suresh Sonamari will give you a separate session.
Separate.
I think
how to stop.
You can enlighten us with all your information. ஒரே நாள்ல உங்ககிட்ட இவ்வளவு வாங்கிட்டோம்னா நம்ம we cannot remember. So, Thanapan sir, you can thank them.
Yes, sir. It's a wonderful session. So we learned a lot. Sir, any comments from Singarodil, sir?
Sir, இல்ல இவ்வளவு இருந்தாரு.
Okay, right, sir. Okay.
Sir, இல்ல நினைக்கிறேன்.
Okay,
sir. Samuel, sir.
Extensive.
Anything to add, sir? I want to learn from you, sir. I want to learn from you, sir, because
Sure, sir.
We had two different, extremely different spectrums. One was a very different and difficult case.
Something I want
so
to.
Very difficult to approach that case. And the other two was a very common problem with we have to know so much of information. Like what Suresh you gave us so much information on a common problem.
Yeah.
So we know that we don't know so much.
When you are taking up the case, the PG thought that it's a very simple, straightforward supracondylar fracture malunion. But அதுல வந்து we can
so much of information
and lot of questions எப்படிலாம் நம்ம trap பண்ண முடியுதுங்கிறதுக்கு it's an example.
So moral of the story, difficult case is easier to pass.
Case is easier to pass than the second and third.
If Suresh Babu comes in, it's difficult to pass.
No.
Another moral of story.
And one more thing I observed, the number of postgraduate attending the session is very high. It's more than 100, 110, something like that. And both Samuel sir and Suresh Babu was attracted and make the PGs to attend. That is the reason I can think.
There is no outflow. It remains static. The count remains static. Till the end of the program, the count
I learned a lot of things from Samuel sir and Singadivil sir is there online.
No, he is not there.
Sir,
Samuel sir is also my teacher and learned a lot of things during his time. Sir is very quiet and used to take evening classes.
Sir, Mohan sir, want to tell something, sir? Mohan sir wants to say something, நினைக்கிறேன். Sir, நீங்க உள்ள வாங்க sir.
Unmute பண்ணுங்க.
Unmute, yeah, unmute.
Unfortunately, I didn't have a chance to work with Samuel sir.
Mohan, you're unmute now.
Yeah, Suresh, it was an excellent, extensive presentation.
Thank you.
He is on the tired.
Ask any question. No scope to ask any question.
ஒரு சிம்பிள் கியூபிட்டஸ் வைரஸ கன்ஃபியூஸ் பண்ணி கொண்டு போய் எக்ஸ்டென்சிவா முடிச்சு விட்டாப்ல.
சார் ஆடியோ கேட்கல சார். ஆடியோ கேட்கல.
கேக்குது சார், நல்லா கேக்குது.
இல்ல எங்களுக்கு நல்லா கேக்குது.
ஓகே, எனக்கு தான் ப்ராப்ளம் நினைக்கிறேன். ஓகே.
உங்களுக்கு இது கனெக்ஷன் ப்ராப்ளம் நினைக்கிறேன்.
ஆமாமா, இந்த இன்டர்நெட் இஸ் அன்ஸ்டேபிள்னு வருது எனக்கு.
ஆமாமா. சார் தானப்பன் சார், நீங்க க்ளோசிங் ரிமார்க்ஸ் அண்ட் பிடிஎஸ் இருக்காரான்னு தெரியல. பிடிஎஸ் இருக்காரு.
இருக்கேன் சார்.
எஸ் சார்.
Sir, very interesting session, sir.
Sir, thank you, sir.
It's not only for postgraduates, so practicing
the general practitioner, yes.
Will be very useful for practicing orthopedic surgery. I'll post in the group. They will see in the YouTube, sir.
Yes, sir. Yes.
Okay, thank you very much. Thank you, Dr. Suresh. Thank you, Dr.
Thank you, sir. Thank you for giving me this opportunity. I thank the entire TNOA organizing committee for giving me this opportunity. This is a wonderful learning experience for everyone, especially for the postgraduate. In the midst of the COVID situations, we are continuing this teaching program. So I want to attend all the PG teaching program in future, so that I want to learn more and more from the senior members, because I was not exposed to the exam cases.
இல்ல நீங்க அந்த லிங்க் உங்களுக்கு வருது, நீங்க அந்த குரூப்ல ஜாயின் பண்ணிடுங்க சுரேஷ்.
Sure, கண்டிப்பா.
That I will PTS and I will send you the link.
Okay.
So that it will be very useful, and you can also see it in YouTube if you don't find time during the program. You can see it in YouTube also.
Thank you.
So PGs were also very interested, sir. There were a lot of interaction was there. Everybody was posting the answers.
Yes.
நீங்க ஒரு question கேட்கும்போது they were posting the answers also. So
they were very attentive.
Actually, PGs answered most of the questions.
Yes, sir. ஒரு 4-5 பேர் பார்த்தேன் சார், திரும்பி ஆன்சர் பண்ணிட்டே இருக்காங்க.
Almost all the questions. They answered almost all the questions.
Almost all the questions from the beginning for the case. Syringomyelia இருந்து எல்லாம் கரெக்ட்டா சொல்றாங்க.
ஆமா.
So I thank you all, sir. Professor Samuel.
Thanks to all of you.
Thank you very much.
PTS Thiru and Suresh, as well as the sponsors Alembic. So the next section will be on
Samuel, sir. Thank you, sir.
Thank you.
Spine, sir. The next section is on spine. Coming Friday, that's a radiology of spine. So I will post it in the group, sir. Thank you all.
So that will also be a very interesting session, sir, because Dr. Venkatesh from CMC is taking, and he's a very experienced teacher with very PG friendly also, and radiology of spine will be the topic, sir. So all the PGs, we request you to join in large numbers and get benefited. Over Tanapan, sir.
Yes, sir. Thank you, sir. So you can call off.
Good night, all of you.
Ramesh, sir, you can call off the program, sir.
And we also thank Alembic also, sir, for every time they've been, Namala, the subject கேட்டுட்டே இருக்கோம். They're always been with us, and we also sincerely thank the Alembic also for having supported us technically and also being with us. Thank you, Ramesh and Mr. Jayesh. Thank you.
Thank you, sir.
Thank you, sir. Thank you.
You can close the program, sir.
Yes, sir. Thank you, sir. Thank you.